approachable and interactive. We organize monthly case discussions, research workshops, competitions, and paper presentations with a vision to build a sustainable, student led club that fosters collaboration, critical thinking, and research culture at GGMC. I am Sejal Zode, and I'll be your moderator for the day. 14th November marks the World Diabetes Day, with this year's WHO theme being Diabetes Across Life Stages. But why are we talking about this metabolic disorder in particular? Diabetes today affects almost 590 million people globally, and what's even more alarming is that 43% of them are unaware that they have it, which further paves the way for complications that are often preventable. India stands at the epicenter of this global burden with nearly 90 million people living with diabetes. Understanding the long term manifestations of diabetes is not just an academic exercise, but also a clinical necessity. And for that, we are truly blessed and grateful to have Dr. Anand Gokani sir as our mentor and chief guest today. With over 35 years of experience as consultant physician and diabetologist, Dr. Anand sir is also a fellow ex-GM site, currently associated with the Bombay Hospital and Medical Research Centre. Sir also has a publication in the UK's prestigious Lancet Medical Journal. He is a renowned diabetologist based in Mumbai, a member of the American Diabetes Association and the National Diabetes Association of India, and it is indeed a moment of pride as Sir had chosen our very own college for the book's launch. Sir, we are beyond grateful for your presence here today and look forward to your valuable inputs and thoughtful insights. With that, let me explain the flow of today's event. We have with us two brilliant UG students from GGMC, Aniha Zadhav from Batch 23 and Sonal Mittal from Batch 24, who will be presenting the case today. Following their presentation, we will be having an interactive discussion with our chief guest, Dr. Anand sir. This segment has been allotted a time slot of 7 minutes. We have our tech team who will be giving us cues with the time limits. After the discussion, Anand sir will be delivering an enlightening talk on the importance of controlling diabetes and the various advances in treating complications. The floor will be open for our audience who may clarify their doubts on today's topic with sir. With that being said, I now invite Aniha and Sonal to present their case. Over to you, Aniha.
Thank you, Sejal. So, good afternoon, everyone. I am Aniha Zadhav, a third year medical student from batch 2023. And today, me along with my friend Miss Sonal Mittal, a second year medical student from JJ Hospital, are going to present a case of diabetic neuropathy and nephropathy. So, let's begin. So, the patient whose case we are going to present today is a 66-year-old male who is an auto rickshaw driver by occupation. He lives in Thane and is Hindu by religion. He presented on 18th November and he presented his he presented on 18th November with his diabetic case on 10 a.m. in medicine OPD. His chief complaints were numbness and burning sensation in both feet since 3 years, swelling of both lower limbs for 1 year. The patient was apparently all right before 2016 when he was diagnosed with type 2 diabetes mellitus. About 3 years ago, he gradually started experiencing tingling, burning pain, and numbness in both the feet. Initially, it was limited to the toes, but slowly it progressed upwards towards the knees, towards the ankles. It aggravated at night and on walking for long durations, but it temporarily relieved with rest and on elevation of legs. Nearly 1 year ago, he developed swelling in both the lower limbs, which was insidious in onset, gradually progressive. It started from ankles and it slowly extended upwards towards the mid chin. This swelling was pitting in nature, associated with tightness of footwear and heaviness in legs. It does not fully subside overnight or with rest and is relieved by elevation of legs. There was no preceding facial puffiness or periorbital swelling. Over the past 6 months, he reports poor appetite, persistent metallic taste, increased fatigue, and a reduced ability to carry out routine household activities. So, coming to the negative history, there was no fever, cough, chest pain, palpitations, or loss of consciousness. No breathlessness at rest was found. There was no orthopnea or PND. There was no history of syncope or leg pain on exertion. No burning micturition or fever. The patient did not complain of any flank pain, hematuria. There was no altered sensorium, headache, or vomiting. No history of falls or bladder incontinence was found. There was no history of TB or TB contact. No nausea, vomiting, abdominal pain, diarrhea, or jaundice was reported. No joint pain or swelling. No non-healing wounds or ulcers on feet. No easy bruising, bleeding gums, or melena was found. The past history of com- the patient was a known case of diabetes and hypertension. So this patient had diabetes in 2016, which was managed by oral hypoglycemic agents, but later on it was shifted to insulin because of poor glycemic control and declining renal function. This patient is also a known case of hypertension who is on regular antihypertensive medicines with BP monitoring. He was also a case, he is also a known case of diabetic nephropathy, which led to chronic kidney disease for 5 years and progressed to end stage renal disease in 2020. He was later started on maintenance hemodialysis thrice weekly due to progressive renal failure with ongoing anemia and electrolyte management. He was also given renoprotective drugs, and there was no history of any previous surgeries. Personal history. The patient consumed mixed diet and he was currently following a renal diet with salt and fluid restriction. His appetite was reduced in past few months. His sleep was disturbed due to fatigue and discomfort. Bowel habits were normal and there was some occasional constipation. The bladder, there was reduced urine output and the patient did not report of any addictions, and there were no known allergies or food allergies or drug allergies found. The patient's father had diabetes mellitus type 2. Coming to the general examination, the patient was examined with due consent in a well lit room in supine position. The patient is well nourished and moderate in build. The physical findings were he was looking chronically ill and fatigued and he had pallor present in lower palpebral conjunctiva, tongue, and nail beds, and his palms were also pale. There was no icterus, clubbing, cyanosis, or lymphadenopathy found. He had bilateral pitting pedal edema, which extended up to mid chin. His skin appeared dry with scratch marks, which is suggestive of uremia, and his nails were pale. There was no clubbing. His tongue was pale and dry. His gait was unsteady due to numbness and reduced proprioception. There were no foot ulcers, callosities, or deformities found. The patient was afebrile to touch. His pulse was 90 beats per minute as measured in right brachial, right radial artery. It was regular in rhythm, adequate in volume. It had normal force, tension, character, and it was bilaterally symmetrical. There was no radioradial or radiofemoral delay found. All the peripheral pulses were felt. Blood pressure as measured on right brachial artery was found to be 150 by 90 mmHg. His respiratory rate was normal. It was 16 cycles per minute and his respiration was thoraco-abdominal. So over to my friend Miss Sonal Mittal.
Thank you. So, coming on to the systemic examination, first we have the central nervous system. Higher mental functions, all cranial nerves were intact. Sensory system, conscious, alert, oriented to time, place, and person. Talking pattern, sensory loss, superficial sensations, in which there was decreased pain, decreased temperature, decreased light touch in distal limbs. Deep sensations were decrease in vibration and decreased proprioception. Coming on to the motor system, we have normal tone. The power in upper limbs, power was 4 by 5 on both right and left sides. In the lower limb, power was again 4 by 5 on both right and left sides. Reflexes, ankle jerk was absent, knee jerk may be reduced, Romberg's test was positive, and higher mental functions were intact. Coming on to the cardiovascular system, S1 and S2 heard normally, soft systolic flow murmur heard over the precordium, no S3, S4 rub heard, peripheral pulses palpable symmetrically, no features of peripheral arterial disease. Coming on to the respiratory system, chest moves symmetrically, air entry bilateral and equal with no adventitious sounds. Trachea was central, no crepitations or wheeze or adventitious sounds heard. Onto the abdominal examination. Abdomen was soft, non-tender, no guarding or rigidity, no hepatosplenomegaly or palpable kidneys, no shifting dullness or fluid film. Bowel sounds were present and normal. The probable diagnosis comes out to be this 66-year-old diabetic and hypertensive male is a probable case of bilaterally symmetrical distal peripheral neuropathy, predominantly in the lower limbs, probably due to diabetes mellitus, and is a previously diagnosed case of diabetic nephropathy, currently on hemodialysis, now presenting with uremic signs and symptoms. The investigation suggested were complete blood count, renal function test, serum electrolytes, urine routine and microscopy, urine protein, albumin, HbA1c, blood sugar profile, serum albumin, ultrasound KUB, nerve conduction study, ECG, and chest X-ray. The confirmatory diagnosis comes out to be end-stage renal disease secondary to diabetic nephropathy, diabetic peripheral neuropathy, anemia of chronic kidney disease. Thank you.
Very well done, Aniha and Sejal. Um, Very comprehensively presented. Um, I just wanted to ask you, I'll ask you a few questions which may be in line with how they ask in exams, maybe with the intention of seeing how you are thinking. In the first sentence, Aniha said that um, he's an auto rickshaw driver. Why is
Yes,
that
sir.
important from this point of view, from his personal disease, this disease point of view?
So, most of his activity was he had no intense physical activity, and whole day he was just he had to sit for a long time.
That could be one, could be a reason for his diabetes to stay out of control. But
Yeah.
considering that he has come to you with peripheral neuropathy and peripheral and diabetic nephropathy, why is auto rickshaw driving important? Without any waste of time, I'll give you the answer. It is when he is driving an auto rickshaw, the floor of the auto rickshaw becomes hot, and most auto rickshaw drivers drive bare feet, if you notice, or with slippers. And when he press the clutch or the brake, then his feet will be which are not sensitive to temperature and vibration will be exposed to repeated trauma, and then he may develop an ulcer, maybe get an injury or a blister which then will fester, and that might lead to an amputation. So
Okay, sir.
his profession might even be risking him to losing his limb, whereas in his profession his limbs are extremely important. So
Yes, sir.
it's important that you mentioned that right in the beginning, but you should know the reason why it is important.
Okay, sir.
When we were in medical college, we were taught that every word spoken should have a reason and not simply to fill in the blanks. So
Okay.
every history should have a reason why it was asked and what whether it is negative or positive. So that
Yes, sir.
was one important point about the auto rickshaw driver's profession, how it how it impacts his disease adversely.
Okay.
I'm sure your colleagues have some questions, and I have yeah, in your history, whilst your colleagues are thinking of some question, in your history you mentioned that he lost many of his sensations. Do
Yes,
you
sir.
know which is, if you have to use this knowledge of diabetic neuropathy, which is the first sensation to be lost? How would you
Um,
detect it in a routine visit in your diabetes clinic? You're sitting in a diabetes clinic or in your own private practice, and a person with diabetes comes to you, and you want to see if he's heading for any peripheral neuropathy. Which sensation would be the first to be lost? And
vib-
sorry,
so he'll be first losing the sense of vibrations.
yes,
So
very good. And so
we
when you have a
firstly,
tuning fork, maybe
hmm,
512 or 256 um, hertz vibrations per second, would be would be good to examine his feet with the tuning fork and see if he can
okay,
appreciate the vibration, because the first symptom to be first sensation to be lost is vibration. Now tell me, why is vibration
okay,
first
sir.
lost? Why is vibration first lost? This calls upon some pathophysiology knowledge.
Mm,
Why not pain, or why not other
so
sensation?
because vibrations are carried by myelinated nerves, and due to
No,
chronic hyper,
they are all myelinated. All the nerves are myelinated.
um,
I'll tell you the answer. It is the vasa nervorum, the vessel
okay,
supplying blood to the nerve, travels
hmm,
through its dead center. So it is right inside the nerve, in the center of the nerve. And so it supplies to the fibers of the nerve from inside, from the center towards the circumference. And the
okay,
vibration fibers are right in the external part of the nerve. So
okay,
diabetes is a disease of microangiopathy, which means affects the vasa nervorum, like it affects the small arteries of the kidney or the heart or the brain, or muscle, leading to their slow demise. So same way in the nerve, when the vasa nervorum become atherosclerosed and start getting blocked,
hmm,
then the first part to suffer is the outermost part of the nerve. And so when
okay,
that
sir.
happens, first sensation to go is vibration. And the other sensations go deeper and deeper. The nerves are arranged in layers in a nerve, the
Hmm,
according to the different faculties of that nerve. So the vibrational fibers are right outside, and then you go inwards till the deepest fibers. So the first fibers to be affected are the nerves supplying vibration.
okay, sir.
That's why we get vibratory loss first. So you do a pinprick examination, and you will find that it is not lost till you have advanced neuropathy, and you're not doing anything to save it. You're not detecting it early, but vibration detect early.
Okay, sir.
And is there anyone in the audience who would like to ask questions? Is the first jerk to be lost is the ankle jerk. Again, I ask why.
Oh,
Is because the ankle is the furthest away from the center,
okay,
and this is again a blood supply business. Nerves are dying because of lack of blood supply. Neuropathy, diabetic neuropathy, is because of lack of blood supply, and if there is even blood supply, is the lack of the ability to use glucose for energy, and therefore the longest nerve will suffer the most, and right at the end will suffer the most. That's why you get
Yes, sir.
peripheral neuropathy, because the fingertips and the toes are the furthest away from the longest nerves supply these areas, and in that the feet are longer than the upper limbs.
Okay.
So that's how the ankle jerk is lost first, and then very advanced neuropathy, even knee jerk is sluggish.
Yes, sir.
In to see creeping nephropathy, would you like to monitor urea, creatinine, or any other test? Which test would you
Sorry,
like to
sir. Could
monitor?
you please repeat your
No.
question?
If you have a patient coming to you with diabetes regularly, what would
Hmm.
you like to monitor to see if there is any onset of nephropathy setting in, or you'd like to warn him that, look, you're not on the right track? Of course, we will endeavor to get good control all the time, but if it is someone coming to you for 5 years or 6 years, you would like to see if anywhere he's
Urine
headed towards.
and so urine albumin or creatinine ratio.
Yeah, that could be one. Which other?
Uh,
You
Also, so
you know about EGFR,
yes, sir.
estimated
It
glomerular
detects
filtration.
the creatinine levels.
Sorry.
Say it detects the decrease in filtration and
Yeah.
before even
So
the creatinine increases.
a normal EGFR is about 100, but
Okay.
as nephropathy starts to come down, set in, if EGFR comes down to 60, your creatinine is still normal, urea is still normal. There may be some degree of microalbuminuria, but EGFR is dropping. And if EGFR drops to a point, you can you can safely say that he's got early nephropathy, and it's not yet florid. Now what your patient has is florid nephropathy, and which is compensated by hemodialysis. So
Yes,
his
sir.
symptoms are not so florid. Like when you said there is no abdominal free fluid, is because his symptoms are not so florid. He's been offloaded in the HD. When
Yes.
they had hemodialysis, they removed extra fluids. But in an untreated patient, you would get you would get fluid everywhere if he was not offloaded by HD. But in the early stages, you will get very minimal edema. If not, you may not get edema, but your EGFR will start falling.
Okay, sir.
It's a calculated entity, not measurable. It is to be calculated from all the various factors.
Okay, sir.
Right. So, audience have any questions?
A gentle reminder, we have another minute for this round and then we'll be moving towards the next segment.
Sejal or Aniha, you have any questions after you make this presentation?
Um, um,
Um,
sir, actually, I wanted to ask his uh, about the nephropathy problem in him.
yes, go ahead.
Uh, Sir, just a minute. There is some disturbance here.
Yeah.
So, how do we confirm that it is diabetic nephropathy? As in, uh,
How do we confirm whether it is diabetic nephropathy versus any other form of nephropathy?
yeah.
Mostly historical.
Okay.
When you take a history and he's got uncontrolled diabetes, and his blood sugars have been high, and his glycosylated hemoglobin has been high, plus he's got proteinuria, then circumstantially he is said to have diabetic nephropathy. And then when you do his, if you want to prove, then you have to do a renal biopsy, where you will get very characteristic signs of diabetic kind of damage. So this the other causes would have symptoms of other diseases. Now diabetes is um coexisting with hypertension, which
Yes,
multiplies the nephropathy risk. So
yes.
it could be both put together, which increases the risk almost 3 to 5 times. And I would say, from whatever experience I have, is that no end organ problem is unifactorial, is multifactorial. Even they say diabetes is a very high risk factor for heart attack. But if you had only diabetes and you didn't smoke or you didn't drink or you had regular exercise, a good diet, and no hypertension, no cholesterol, then it's very likely every disease, every end organ problem is a multifactorial problem, and it is generally contributed by all the factors. So, no one typical symptom or typical sign which will assign a like say this is diabetic nephropathy, but nephropathy is there, and that is generally seen in a background of diabetes. So you say diabetic nephropathy. There are very subtle and characteristic histopathological symptoms, signs, but I'm not the expert in that. I know one thing, that the treatment will remain the same. And if I have a case with diabetes and hypertension and several other risk factors, then it calls for the treatment of all the risk factors, and the nephropathy is the end result, whether nephropathy or or neuropathy.
Thank you, sir.
We have time for more questions. I think our so
Proceed with the next segment.
Sejal, you want to move with the next phase?
Yes, sir. Thank you so much for your valuable insights on this case. Now, I would like to invite you to share your opinions on the importance of controlling diabetes and the various advances in treating complications.
And how are we doing with time? How much time are we having now to do this discussion? About
So, we have
60.
quite some time.
Okay,
Yeah,
so you give me a heads up if there is time if we are exceeding time. Yeah.
yes, sir.
Now,
Great.
I'm going to take this opportunity to tell you some things which I have learned over the years and didn't know well at your stage. First thing is that when I did physiology, um, I physiology was attached with biochemistry. We didn't have like you a separate biochemistry paper. We had one section in out of four sections dedicated to biochemistry. So for us, biochemistry was number one, a very boring subject, too much to memorize. And secondly, we just wanted to get pass marks so that we get out of first MBBS unscathed and go to second MBBS. And we were very keen to get into the wards and see patients rather than simply learn theory. So we neglected all the details of all the biochemical cycles. Thereafter, I joined diabetes as a registrar, as first as a houseman, and thereafter as a registrar, because it was more like a write-off unit where you didn't have any other job, you took that job. So, treating it in that light, that time diabetes was not or as rampant as it is today. It was maybe there were about 1 lakh patients in Bombay, whereas now they may be far in excess, maybe much more than that. It's something that we can never estimate how much diabetes has increased. You have mentioned in your introduction, Sejal, that we have 90 million diabetics in India. My estimation was that 5 years back it was 57 million, as per the WHO. But it was projected that in 5 years it will be 65 million. But if the real fact is that it's 90 million, I'm not surprised. And the reason for this is that we have not understood diabetes from the core, and we only learned how to treat it. So when I was sitting idle in my clinic in private practice, right in the beginning of my practice, I decided to revisit the basics of diabetes. And I realized that diabetes is Krebs cycle gone wrong. Now then I opened the Krebs cycle from the very same book which I treated stepmotherly, and I looked at it in detail, and it says glucose becomes glucose 1,6 phosphate, glucose 6 phosphate, and that becomes 1,6 diphosphate, and it goes on further and further and further, and finally blows off into carbon dioxide and water. But what is on the arrow are the small print. And in the small print, there was potassium somewhere, magnesium somewhere, manganese somewhere, NAD becoming NADP somewhere, FAD becoming something. And I figured to myself, I said, these are not just simply alphabets, but these are vitamins and minerals. So suppose at any point in any arrow, if one of them was absent, then will the cycle move forward? Then I looked at diabetes from a completely different angle, and this is what I'm going to explain to you. That whatever we eat is digested into its very basic units, and that for carbohydrate, the basic unit is glucose. And since we are not talking about protein and fat metabolism today, let's just look at carbohydrate. That all the carbohydrates in our body, in our diet, will get converted to glucose in the intestine and then be absorbed, taken to the liver, and stored in the liver and then dispersed to the rest of the body via the bloodstream to every cell in the body. Because every cell in the body uses glucose to, to produce energy, because glucose is the energy currency of our body. But to burn glucose, according to Krebs cycle, we require vitamins and minerals, and we require insulin to burn it faster. So let's take glucose to look like wood, and we need matchsticks to ignite the wood. So glucose is wood, then vitamins and minerals are matchsticks. And then we need a fan to fan the fire to make it burn brighter. That fan is insulin, it's the catalyst. And this is the equation externally where wood burns with the help of matchsticks and a fans the fire to make it burn brightly to give us heat and light. And that heat and light is referred to as energy. So every cell in our body takes glucose, burns it with the help of vitamins and minerals, and insulin hastens that burning to produce energy for our everyday activities. So whether it is the liver cell or the nerve cell, brain cell, heart cell, muscle cell, bone cell, any cell, all the cells require glucose to produce energy. But suppose vitamin mineral is absent, then this equation of glucose burning to give energy will be stuck. And if glucose is not burnt, then energy will decline, and glucose, when measured in the blood, will be piling up. That is what we call diabetes. So, if nature made this system of glucose requiring vitamins and minerals, it packed the glucose and vitamins and minerals together in food which we eat every day, and that is fruit and salad. If grandmother used to say, a carrot a day keeps the doctor away, or an apple a day keeps the doctor away. The reason is that a carrot and an apple are both representative of fruit and vegetable. So if you have fruits and vegetables in abundance, then you have enough glucose as well as vitamins and minerals to serve you through the day so that you have a healthy and productive life. So this was the principle. Uncooked food like glucose or like salad and fruit, they supply us with vitamins and minerals. But cooking takes away vitamins and minerals. So if you steam the food, you lose 20%. If you boil the food, you lose 40%. If you pan fry the food, you lose 60%. If you fry the food, you lose 90 to 100%. If you microwave the food, you even get loss of 120%. And this is how we destroy food by cooking it. But when we were born, this is a side twist. When we were born, we took 10% of mother's stock. Now I'm very highly simplifying genetics or the inheritance or heredity. We say diabetes is hereditary. Even in your history, you mentioned that there was a family history of diabetes from the father. Family history, I'm simplifying and showing you how family history acts. And that is when you were born in the 9 months, you took X amount of vitamins and minerals from mother's blood and stored it in your liver as your starting capital. Now, when you were born and after that you were given the first cooked food, let's say the first chocolate on your birthday or the first roti sabji dal chawal, then that came inside the blood, the glucose came inside the blood, stole the vitamins and minerals from the liver and produced energy. So we got energy from that food. So society declared that that food should be the best food, and we kept enjoying that food. And having grown up eating that food kept stealing vitamins and minerals from the liver. If your liver had a very good stock, or you kept replenishing that stock, it never finished. But if that liver was given a smaller stock and you kept using it up indiscreetly, as you grew older, 25, 30, 35, 40, at some stage that stock finished. And once that stock finished, now when your next stock of glucose arrives, there is no vitamins and minerals. And as a result, the glucose will not burn to produce energy, and as a result there will be a pile up of glucose, and that pile up when measured will show us high blood sugar. So this first cause of diabetes is our changed diet, which is lacking in vitamins and minerals. And so the first treatment of diabetes is to go back to that natural diet where you can restock that vitamin and mineral so that we can uh, reduce that diabetes or get it better to control and need lesser medications in some cases. So that's the first point. The second point is that when we have uh, when our diet has some acid in it, there are certain class of foods which are acidic, and this acid lands on the pancreas and burns the pancreas. So pancreas is eternally on fire, sometimes a low grade fire, sometimes a high grade fire. And that persistent firing of the pancreas gradually makes the pancreas sick, and then some of the cells keep dying. And this is on an ongoing basis. There comes a time in your life when a critical mass of cells are destroyed, and what's left is unable to meet the daily demands of insulin. And as a result, um, your insulin starts to drop. And as the insulin drops, your sugar takes longer to burn. And as a result, there is a pile up. For example, you have a 8-lane highway which converges on a 2-lane bridge. There will be a traffic jam. The same thing happens in the body vis-a-vis glucose. And so your glucose starts to pile up. So theoretically, if someone asks you, can you cure diabetes? Then I say, yes, you can. But what you have to do to cure it is extremely difficult. And if you can do it, you can even dream of a cure. You can't just hope for it. And there is no wand that can be magically waved to create to take away diabetes from you. So, what are the things that burn the pancreas? What is this acid that we eat? Is the next question. This acid that we eat is there in innocuous foods that we eat every day. And the list is in the black and white list with no compromise, with no concession. This list does contain 10 families of food. 10 families of food starts with alcohol. All alcoholic beverages, they damage the pancreas on touch. Thereafter, How much we choose to damage the pancreas is a personal choice. But the knowledge that all alcoholic beverages are, are acid and acid burns the pancreas is without compromise. The next family of drugs is tobacco. Whether you smoke it or you chew it or you pipe or in a pipe or in any other form, tobacco burns the pancreas. Third is fried food. When you fry food, you create toxins of that highly highly boiled oil, and that toxin also hurts the pancreas. The fourth is very spicy food, especially red chili powder. There are grades of chili powder. I'm not going to go into that, but chili powder is acidic. I tell my patients, if you can't put it in your eye, you can't put it in your stomach. And red chili goes in the eye, it smarts like very severely. But if it goes in the stomach, we don't appreciate that feeling. But if it goes and hits the pancreas, it causes damage there also. And so, red chili is the fourth acidic class. The fifth and sixth are tea and coffee. Tea and coffee are actually not food; they are drugs. When I say tea and coffee, I'm speaking strictly only tea and coffee, and not the milk and sugar that goes with it. Milk and sugar come in the next compartment. But tea and coffee are caffeine, theophylline, theobromine, and tannic acid, which are four drugs. And these four drugs, they steal from the liver and they hurt tissues, including the pancreatic tissue. Then comes four white poisons, which are milk, maida, sugar, and salt. And all four of them are innocuous. We eat every day without even a thought, but they are very strongly acidic, especially sugar products and maida products. So we can discuss on these in during question answer, but these four are acidic in nature. And the last is all non-vegetarian products, particularly if you can't digest them. If you don't digest them, they ferment in your intestine, giving very powerful organic acids, which can then harm organs, particularly bones, pancreas, brain, and liver tissue. So these are 10 to 11 families of food which cause acidic burn to organs. Pancreas being the organ in question, pancreas get damaged by the same mechanism. So if we are able to audit this list in our day-to-day diet, or if you take a diet history from a patient and see how much of this he is eating, then you can reduce it to 20 by to 20%. Reduce it by 80% to 20%, which means you stop four-fifth of that how much you are taking, and you can allow your pancreas to recover. The amount of pancreas that is sick can recover. The amount that is dead will not recover. So this is as far as your diet is concerned. The second cause of diabetes is this assault with acidic foods. The third is a unspoken thing which we have never discussed, which is stress. Now, when I say stress, do you want to take a question or two at this point? Sejal, can you unmute, and would I
Yes, sir.
be out of place if I ask a couple of questions at this point? And I'll
No, sir.
say
We'd love
if
to have your questions.
anyone like to volunteer the definition of stress and tell me what they think is their concept of stress.
I feel biologically, if we're speaking biologically, stress would be like any emotional or physical state that is causing the release of cortisol, which is the stress
Hormone.
releasing hormone.
Yeah.
And that cortisol kind of is hyperglycemic in its action, and therefore it causes increase in blood sugar levels.
Yeah, very scientifically put. Tell me in lay language, how will you question the patient as to what these emotions? Can you name some of the emotions?
One would be, let's say, anger. One would be
Absolutely.
based on the sleep wake cycles that are completely deranged,
Yeah.
which I think is something that goes unnoticed.
Yes.
Then it could be. Probably the psychological states of depression
Yeah,
and
very true.
anxiety.
Brilliant. Kethabji, perfect answer. I uh, I'd say stress is defined as pent up negative emotions. We will feel all these emotions every day, all of us do. But we express them and we forget about them. But for those who keep it pent up, for example, pent up anger, pent up hatred, pent up jealousy, greed, grief, guilt, fear, anxiety, depression, loneliness, all these, if they are kept pent up inside, they continuously build up cortisol. And as you very rightly said, this cortisol is hyperglycemic, and so along with it, also adrenaline, noradrenaline, all are hyperglycemic. And when all of these hormones come in large amount in your blood on a continuous level, then the amount of glucose produced is far in excess to the amount we can use for energy. So stress is the silent reason why diabetes keeps increasing, and it becomes of a good diabetes specialist or even a good physician to take a stress history. And very strangely, we were told in medical college that the best stress history answers you can get are at 3 a.m. in the morning. It's a very difficult time for a houseman to go to the wards and ask. But if you happen to be in the wards and if you happen to go and talk to your patient at that hour, he is most vulnerable. And at that time, he will speak to you everything that you want to know. But in the daytime, he'll probably conceal everything and you won't get to the bottom of his problem. But if you are able to diffuse this stress, sometimes you can make do with half the dose of insulin. Whereas when you don't diffuse it, you can keep stepping up the dose of insulin or tablets, and blood sugar still remains high because insulin is countered by all these other hormones. So that's about stress. And the last cause is lack of exercise. Now, this has a yoga link. Exercise means movement of all joints. If you keep all your joints supple, they can only be done by continuous movement. And continuous movement has continuous nervous connection with pancreas. So you stimulate that nerve which awakens and excites the pancreas to make insulin. So if you can willfully move your joints to willfully get your pancreas started to work, but you cannot will your pancreas to make more insulin. So if you have a sedentary life and then go to the canteen and have a cake, you can't tell your pancreas, listen, I want more insulin. But if you go for a 1 mile walk, the act of walking will stimulate insulin production, and then that production will take care of whatever sugar that is necessary, that has come in from the diet or from other reasons. So these are the four main causes of diabetes. And when you look at it, this is not how our books have portrayed it. Our books have portrayed it in a very different way. We look at all the sophisticated theories and the different mechanisms of action. But when I when I see diabetes in this very simplified way, I realized that what my job is, that when glucose is elevated in my patient, I have to restore his vitamins and minerals. I have to restore the action of his insulin. And if I can get all four of these things together, the glucose will easily burn, produce energy, and restore well being in my patient. And so, all techniques that legitimately act towards this goal are acceptable treatments of diabetes. What I said last is an extremely profound statement. I'm not saying it because I coined it, but I'm saying it because I realized it. I realized that treatment of diabetes, which would have been to normalize metabolism, when we treat diabetes, we want to normalize metabolism. The normal metabolism is glucose burns to produce energy and thereby keeps the cell energetic. When all the cells are energetic, you as a whole are energetic. But if glucose cannot burn, the cell becomes tired, and that leads to yourself becoming tired. Now, when you go to the doctor, you say, I am tired. There are illness levels, there are blood sugar levels. So you say your blood sugar is high, that's why you're tired. Now we have a in the measurable commodity which can be quantified to corroborate with the patient's symptom. So every time he comes back and he says, I'm tired, you measure his sugar and his sugar is high, you say your diabetes is not controlled, control it and teach him how to control it. Originally, there were medications which helped the insulin by either stimulating more insulin, the ones the sulfonylureas, which went to the pancreas and produced more insulin. And there was the metformin type biguanides, which increased the efficiency of insulin. And together, we were able to capitalize on the best action of insulin. So you have sulfonylurea making more insulin from the pancreas, and you have metformin making that insulin more efficient at the cellular level. And this way, you could get very good diabetes control because glucose got used, it produced energy, and the patient come back say, "I'm feeling quantum better in terms of energy, in well-being, and so on." But after some time, researchers as well as physicians start treating diabetes as a blood sugar problem, not as an energy problem. So we start looking at the treatment and say we need to get blood sugar normal at any cost. And so came the advent of medications which are there in the market today, which are there, and you will have to learn about them in pharmacology, and you will have to give their answer in exams that this could be the dose and this could be the side effects. But to my mind, they are not legitimate drugs in the treatment of diabetes, and those are the drugs that interfere with digestion by blocking enzymes and thereby are asking you to eat but not allowing the food to be digested. And as a result, there is less entry of blood sugar and therefore there is no sugar. And so you get normal blood sugar or better blood sugar. But there is still no sugar for using and therefore the cells are still tired. So patient may come back to you saying, I'm tired. You say, oh, there could be many reasons for it, but your blood sugar is normal, which is not the treatment of diabetes. And the second is those that allow for leakage of glucose in the urine. There is an entire family of drugs which prevent the reabsorption of glucose in the nephron and allow it to pass out as glycosuria and that way leak the sugar from the blood, thereby reducing the sugar burden in the blood and causing a lower blood sugar level. To my mind, both these drugs are not legitimate treatments for diabetes, though they are very rampant in the market. That is one observation I made as far as treatment of diabetes is concerned at this present moment. And then comes the other drugs which have got several side effects. You read newspaper today. I remember when I was in medical college, I was into practice, maybe 5 years into practice, and I learned about the glitter zones, which are there in every pharmac book now, on the front page of Economic Times, not a medical journal. The first time I heard of a glitter zone was on the front page of Economic Times. On the lower part, that Park Davis drug Resulin is has swamped the market, and the share prices of Park Davis gone sky high. Why? Because Resulin has saved millions of people from the deadly jab, which was referring to insulin. So everyone started switching to troglitazone, and troglitazone was used liberally for 3 years. After 3 years, on page 5 of Economic Times, I read a small article. Park Davis withdraws troglitazone, and inside you read 11 cases of acute hepatic uh, necrosis, which was not even amenable to liver transplant, and such patients died. 11 deaths directly related to troglitazone. But in 3 years, they made so much money. After that, they brought in its congeners, pioglitazone and rosiglitazone, and they gave black box warning. And when you see a black box warning, it means the company has absolved itself of any responsibility if there is a symptom, if there is a side effect that could be lethal or even debilitating. But we disregard these black box warnings because they are in very small print and continue to use the drug not knowing that the company is not going to stand by you if something goes wrong. So it's very important for us to read a product monogram or the monograph of that drug before we use it, because it takes 3 years for you to see side effects, see certain new drugs in the diabetes market. They, for example, incretin. There is a drug that prolongs the life of incretin. You see in the newspapers every day these weight loss drugs. They act through the mediation of incretin, and incretin actually promotes mitosis also. It's one of the significant effects of incretin to promote mitosis, and mitosis is a characteristic of malignancy. So increased incretin has caused an increased incidence of malignancy, and that could be directly a result of anti-diabetic treatment. So we are stepping on areas which are very dicey, very dangerous, and very stimulating at the same time. But it calls for a very a responsible attitude on our part as physicians. And so, diabetes today is not just a chapter in Harrison. Diabetes is more than 2 volumes of book only dedicated to diabetes, because between the lines, between each line of Harrison is written a full book, and therefore it's very important to be very careful, because today almost 40 to 50% of the load in any medical OPD, general or otherwise, is is a person suffering from a disease along with diabetes. And so there's not going to be any case which is coming without diabetes, because diabetes makes them more prone to illness, makes them more prone to all complications, non communicable and communicable. So all of us will have to be familiar with diabetes. And sometimes I believe, and this is a pharma dictum I have, that if a drug is old, it only becomes old when it is safe, it is effective, and it is cheap. If it is cheap, people keep buying it, so it becomes old. If it is safe, people keep using it, so it becomes old. And uh, if it is effective, only then people keep prescribing it, so it becomes old. So an old drug is a valued thing. A new drug is a dangerous thing, needs to stand the test of time. Whereas if you are going to buy a new cell phone or a new watch, then you may say, I want the latest in technology. But when it comes to drugs, take the ones which are the oldest, because they became old only because of these three characteristics. And this again is not promoted by pharma company, because pharma company wants to try, as soon as a new drug is brought in, the old drug becomes taboo, because they've made enough money on that drug. They want to make money on new drugs, and that's where we have to use our discriminatory power. So I think I might have opened up a Pandora's box of thought in your minds as far as diabetes is concerned. I think I might be now dangerously bordering on overdose. So let's take questions before I can go on any further. Sejal, you
So,
want to you coordinate the questions?
Yes, sir. The floor is now open to the audience. If anyone has any questions, they are free to ask.
Kaitabjit, go ahead.
yes, sir. So I had a question. So basically, as you must have noticed, the cutoff values for diabetes and rather many other non-communicable diseases over the years has decreased. be it
Yeah.
hypertension, be it diabetes, be it other things.
Yeah. Do you
And
have any idea
sometimes
why?
that is what I'm coming to. And sometimes, like, even my grandparents, they'll
Yeah.
have impaired glucose tolerance according to those cutoff values, but
Yeah.
they'll feel perfectly well and they'll deny any sort of treatment and medications.
They're
so
very wise.
somewhere so somewhere I believe is that as doctors we have started to look at those trusting more of those biochemical values and all those lab reports than what the person is actually feeling.
Yes.
So, where does the conscience of a doctor, or where does a doctor stand in its, should he follow the guidelines and what is
No.
prescribed by textbooks,
See,
or what?
I'll tell you, the people who do the guidelines are brought together by pharma companies. The pharma companies give the end point. The end point is that all guidelines should point to a greater sale in the drugs. And when you drop the value of blood sugar, let's say, there is a normal value, whatever normal values which are printed in a normal report. You see, when you see the column of normal values, those values are applicable to those people less than 50 years of age. But that's not mentioned. All values are less than 50 years of age. After 50, you have to have a concession to those values because of the aging process. So, for example, 120 fasting blood sugar 120 or less is normal. 121 is not diabetes. If you see the age and it's 50 to 60, then you add 10 to the value of 120 and becomes 130 is normal. 60 to 70, 140 is normal. 70 to 80, 150 is normal. And likewise, you go up to 100. And I think after 90, you don't have to question because if he reached up to 90, he knows what he is doing and therefore don't need to advise too much. So there is a different normal for different age in every disease. For example, let's say blood pressure. 120 by 80 is a number for less than 50. As you grow older, you appreciate that blood has to be pumped against gravity from the heart to the brain. And if there is atherosclerosis, mild atherosclerosis of the carotids, whether inside the skull or in the neck, then your heart has to pump harder to get to the brain in the standing position. And therefore, the systolic blood pressure is prone to rise. And when it rises, you will get a systolic hypertension according to the definition of the normal values. But if you lower that with the blood pressure medication, in order to get this magical 120 by 80 number, then you are cutting the ability of the heart to pump blood to the brain and then land up as fertile material to produce a stroke. So it's very important for us to keep our head on our shoulders and realize that every every innovation is farmer driven, and farmer driven research is when they have conflict of interest statements, you will read in very fine print that their entire research was funded by the company that produces the drug, in which case there is a severe conflict of interest, and then the research has no value because they will never write anything critical about the drug when it comes uh, to making a policy. So all this lowering of values, lowering of cholesterol, sugar, and blood pressure is to sell more drugs. Cholesterol also, first it used to be less than 250, now 200, now 160. And when I had my first brush with heart problems, I was told that I must keep my cholesterol less than 100, total cholesterol. And it's virtually impossible with diet and exercise. So I have to take a statin. Then I realized I'm getting so many side effects with statin that I stopped statins. And I said, I'll be a law unto myself. I will let it be around 150. And at that level, I'm good both ways. No side effect of statin as well as a safe number. But you're right, Kaitav. Your your these observations on lowering of values is having serious ulterior motives.
But sir, like just a follow-up question. I think at this point of time, our entire education is completely sabotaged by this pharma-based research. So how
Yeah.
do we break that sort of pattern? Because
See, the text gives you the equipment to think. It doesn't give you the final answer. Because if you realize, textbooks have new editions every 2 3 years, which means what was 2 years back, that opinion has been rubbed off and was invalid when someone 2 years later writes his opinion. So again, we are just being dictated by opinions, not by any hardcore. The hardcore truth remains hardcore. That never changes. In medicine also there are certain things that never change. Every textbook, every edition will say the same thing. But it will be certain things that change. So we need to look into what is changing and what is not changing. Learn the thinking process and then ask your questions yourself. Because tomorrow, today you are reading, it's very possible that tomorrow you will be writing the book because you are thinking different. And your thought process make you a better and different physician or surgeon or any faculty in medicine that you choose to follow, because it's only the thinking person who can innovate on pathways which are hitherto unexplored. You should not blindly follow what is given. Analyze it on the basis of what you have learned.
right, sir. Thank you so much.
Pleasure. Who else? Two other students had raised their hands. Who are they? Yes, Abresh.
Uh, Good evening, sir.
Good evening.
Firstly, really different perspective you presented of looking towards diabetes, by interpreting the Krebs cycle itself and, going into the crux of the pathophysiology. So that was a really innovative insight that
You know,
I,
Abresh, when I was a student, no one told me the importance of biochemistry. They didn't tell me that biochemistry is the backbone of full medicine, metabolic disease. I
I very much
discovered
agree, sir.
way after that.
I think because of guidance of insightful professors like you, we have started to realize the importance of biochemistry at a very juvenile age, so that we
This
won't
is which
ignore it
you're.
just as a
I'm
subject to
very,
pass.
I'm very happy for you because
Sir,
yeah,
I just had a question to ask. Now
yeah,
that when we study diabetes from any kind of textual resource, the classification of diabetes which has been provided,
hmm,
apart from the classical type 1 and type 2 diabetes that we have been studying about since ages, since the
yeah,
time
yeah,
diabetes was properly studied, now there
yes,
are a lot of other classes. Like there is type 3
yeah,
diabetes, there is type
yeah.
1.5 diabetes, which has now recently emerged,
You say these
which
are
is the
these are
LADA and ketosis prone.
yeah.
So,
These
sir,
are every
mhm,
classification either is treatment or driven, means according to the treatment you give or according to the etiology of the disease. So
okay.
classifications are good for theoretical discussion. There's
Mhm.
only there's only two types of diabetes. There is one
One
which
and
needs
two.
insulin to survive, and one that
Yeah.
doesn't need insulin to survive. And if you know this much is more than enough. It's a type 1, type 2, or type 1.5. Type 1.5 is type 2 is what we called insulin requiring diabetes, not dependent.
Y-
Means
Yes, sir.
without it, he won't die, but he'll go into ketones, not ketoacidosis. You'll have
Yeah, but
ketosis.
ketosis would
You'll
be
have
there.
ketosis with high sugar, but
Yes,
not
sir.
acidosis.
So,
So
so these
those,
classes are not very much like clinically seen or clinically prevalent. It's just for the text
yeah,
theoretical aspect of it.
yeah, it is someone expressing his opinion and making
Okay.
himself immortalized by making a classification on his name. But otherwise, it's a
Okay.
very standard thing.
Okay,
So
okay. Thank you so much, sir.
no problem. Who was the other person who wanted to ask?
Do we have any more questions from the audience?
Sejal, do you have any question?
Sir, I personally believe that in spite of being medical students, we are not leading a very healthy lifestyle. I just want to know that
No.
in your clinical practice, what is
Yeah.
your experience with people who fall in our age group, our demographic area, and what is their current status when it comes to diabetes? Like, are they falling in the pre-diabetic range? Are they at a high risk?
No, they are not in the pre-diabetic range. But I agree that medical education, medical college life, from the time you enter first MBBS, right up to the time you may finish with MD or MS or whatever super specialty you want to do, it's about a span of 10 to 12 years. And in those 12, 10 to 12 years, your every system in the body gets pummeled so badly, so viciously, that it's a surprising thing they don't come out with a disease. We have the absolutely wrong perception that diabetes is something which is maybe we reached a turning point. Maybe your generation will be turning the tide on its own. Will eat more healthy and have more disciplined lives and save yourself for later. I remember our head of department anatomy when we joined medical college. First 1 week we had a spot test, and it was the upper limb spot test. So we had to go around for 10 questions, and all of us were so scared that it was the first test in medical college education that we had our Cunningham open and we were standing outside Anat Hall and revising last minute. And this professor, who used to be very tall and huge, she was maybe 120 kilos and had a booming voice. She came right onto the door entrance and she yelled at us. She says, "What is this nonsense? Why are you all so nervous? Why are you all reading last minute?" Said, "Today is the first test in your life, and this kind of test is going to happen every week, and it's going to happen for next 10 years, and after that it will happen every day, because every patient will be a test. And if you do what you're doing just now, you will exhaust your adrenal gland, and there will be nothing left for you after second MBBS. So sit down, relax, smile, laugh, and go and attempt the exam. If you don't do that, you'll are written off." And she said this and went away. And we all closed our books, looked at each other sheepishly, and went and wrote the exam. All of us did well. But we learned one thing, that in that midst of all the adversity, we need to maintain a kind of equanimity. And that equanimity is what sees you through as a survivor rather than as a person destroyed by the process.
That was truly insightful, sir. Thank you so much.
Sejal, more questions? Anyone? I
Any more
can't
questions from the
see
audience?
everybody. Can we have everyone put on their videos? I get a look to see. Thanks, Ketan, your leader. All the others, let me see what you all look like. And if there are any more questions, many will come up. Many questions will come up. Many may even feel hesitant to ask. I used to be very hesitant to ask when I was a student, because I used to feel that others may feel that my question is stupid and I should probably know the answer, so I can't ask. But if questions arise, make note of them, and and open the books or ask people and get us that satisfactory answer. You don't have to accept every answer. You don't have to accept what I said also. You scrutinize what I said. You scrutinize it properly till it is ingrained in your head. And then finally, you will have what suits you. And what theory suits you, you adopt for life. Of course, you review it time and again with new knowledge, new experience. So, I think if we are at the end of our meeting, how's the timing, Sejal? Are we on time?
I think we should be wrapping up with the question answer session. If we do not have any more questions from the audience, shall we move ahead?
Yeah.
Okay, I believe we don't have any more.
No.
Sir, it is indeed true that most of us did treat biochemistry as if it was an evil stepmother. But your analogy has given us a new perspective about how we can deal with this cumbersome subject. Again, I want to admit it that in spite of being medical students, we even feel a kind of confidence about
Sorry, Sejal, your last words are lost. Somewhere we had a little disturbance. Just say that last bit again.
the biochemistry Sir, am I audible now?
You're getting cut off. Am I the only one not receiving you?
No, sir. I think she is facing some issues from her side.
Yeah. Petab, you could get the entire statement.
No,
Hello,
sir, even I
Sejal.
didn't hear.
Sejal, you're there?
Sir, am I audible now?
Sejal, if you want, you can try rejoining the meet because your voice is getting cut off a bit.
Hello, can everyone hear me now?
Yeah, I can hear you.
Okay. So yeah, it was that only what I was admitting that most of us did treat biochemistry as if it was an evil stepmother.
Yeah.
But for sure, your analogy has given us a new perspective on this subject. And again, I would like to admit on behalf of all my colleagues that we do not pay enough attention to the kind of food that we consume, especially the processed one.
I
We do not
was
read the package
I
labels.
was worse than that.
Yes, that is I believe you can do better in that regard. And truly, sir, your clinical insights are some of the knowledge pearls that most of us will be cherishing forever. A lot of
Thank you.
real knowledge which textbooks might skip on, we were fortunate enough to gain from you today. Truly grateful
Thank
for
you.
that, sir. And the Pandora's box which you have opened indeed has started a chain reaction in all our minds. And I hope that we all can begin to brainstorm a bit more and bring into practice at
Yeah.
least some of the takeaways that we got from you today. Thank you so much, sir.
Thank you so much, Sejal, and all of you for listening. And I feel happy and privileged to be with you all. And I've been really fortunate that I've had maybe the third time to interact with all of you. So I'm getting a bit addicted to it. So let's hope we meet again
So we love
sometime
it
very
too.
soon. Thank you.
I
Thanks so
think,
much.
sir,
Yes,
your
sir.
thoughts will change all of our way of reading medicine completely. Like for me today, I think I have decided maybe it's a different way I should approach medicine and reading textbooks now. So I think it's the same
I
for all of us over here. And
I'll ask you as a parting gift one question. Did the WBC count rise first or did the infection come first? Think about it.
so the infection should be coming first.
And then what happens? See, I'll tell
Then to
you. I
fight it,
know.
we have to.
See. I'll give you my little insight. We were always taught the infection comes and the WBC count rises. Then I realized that suppose someone who is infection free has a count of 8,000 and he doesn't get an infection, but someone gets an infection And then we check his count and it's 14,000. Did it rise first or did the infection rise first? Then I realized that WBCs are like army men with ammunition, guns, and grenades. And they are walking around your blood and killing any bacteria on site to keep you healthy. Suppose the ammunition is exhausted, their guns are defunct, and they are all alcoholic. When I say alcoholic, you know what happens, how WBC becomes alcoholic through our medium. But if they are all like that, then they are unable to fight bacteria, either unable to recognize them or unable to fight them. And so bacteria come in larger number and multiply. And as they multiply, many chemotactic agents are released, and suddenly we realize that our army is not enough. 8,000 is not enough. Step it up to 1,400, 14,000, or 20,000. And all 20,000 come. All 20,000 are like that only. And therefore, infection become more rampant. And the WBC keeps on rising to match an infection ineffectively. Till you use antibiotics is an external help to crush the infection, and then gradually the WBC comes down. But you are prone to infection again because the same WBC has not yet been well equipped with ammunition. Now, when I get this understanding, I realize that WBC count only an infection indicator, whether to treat it as viral or treat it as bacterial. After that, you have to do so many other things. Improve the patient's diet, hydration, rest, in order to give the WBC better ammunition so that it is capable of looking after when you withdraw the antibiotic. And it changed my whole perspective of medicine. Means I start treating in a different way and I start looking to the dietitian for help more often than treat it as a piece of furniture. I mean, most people treat dietitian as a assistant with no meaning at all. But here in my clinic, mostly the dietitian is prime medicine. After that comes other things, supporting. Anyway, this is just a teaser, so that you go and think about it. But the more you think about medicine, the more you question what's written in the book, the more you'll learn, and the more excited you'll get about your profession. Otherwise, it's learn by heart, do exactly as the book, treat patients, never cure them. But let's part on the good note that we all have learned something. Thank you all.
I- Indeed, so we have learned a lot today. And
I'm glad. I
as we
really
come,
love I really love feedback from all of you, and not just kind words to you say to someone who's older than you. I'd like to know whether you actually learned and if you actually benefited, because I can then maybe we can plan more talks, more interactions where I can share some of my experiences with you all. I'm very happy to do that because it'll make more clones of me, more people who think differently and out of the box. And I wouldn't find any better candidates than all of you. I have
so yes,
enjoyed all the three meetings I've had with you all, and it's been. I look forward to more. Thank you.
so it was an honor to have you in each of the meetings that we have had till now. And truly, we look forward to more collaborations with you in future. And
Thank
our
you.
team will see to it that we are able to organize more such talks. And probably next time we'll try to get an offline meet where the students can actually meet you and have some
Yeah,
discussions with you.
lovely. We could do that.
Yes.
All the
Yes.
best.
Okay.
Are we done
As
with the
we
meeting?
come, yeah, we'll just go ahead with the closing remarks.
Yeah.
As we come to the end of this insightful event, I would like to take a moment to express our heartfelt gratitude to everyone who made this event meaningful. First and foremost, our sincere thanks to our chief guest, Dr. Anand sir, for gracing this event with your presence. Your guidance, your words of wisdom, and your encouragement have truly enriched today's session. We are honored and deeply grateful to have had you with us, sir, today. A special appreciation to the organizing team at the GGMC Journal Club for their dedication, careful planning, and tireless efforts behind the scenes. To our audience, thank you for your participation and the enthusiasm that you brought to the discussion. Your presence is what gives purpose to such events, and we value the time you took out to be here with us today. With that, we conclude today's session. We look forward to meeting you all next month with another engaging case discussion. Have a wonderful day ahead, everyone, and thank you so much.
Thank you so much, all of you.
Thank you so much, sir.
Thank you so much, sir.
Thank you so much, sir.
Thank you,
Thank
sir.
you,
Thank you.
sir. So much, sir.
Thank you.
Thank you, sir.
Bye. Bye.